Good morning, everyone. I'm Beyda. We're going to be talking about emergency airway management. Okay, so I'd like to start out with a case. You got a 55-year-old male with worsening shortness of breath, cough, and fever. It's not COVID, times 1 day. Vital signs, blood pressure is 80/50, heart rate's 135, tachypneic at 30, saturating 88%. Scar 101, finger 6, 300, BMI is 45. Clinically, he's toxic appearing, he's diaphoretic, and he has increased work of breathing, as well as right-sided diminished breath sounds and rales. You initiate initial interventions, including high flow nasal cannula, and then escalate up to non-invasive positive pressure ventilation with minimal improvement. So the decision is, should you intubate this patient? And just for some situational awareness, you just completed 2 traumas that were sick enough to go up to the OR, so your trauma team is occupied. ENT is in a busy flap case. It's going to take about 8 hours. The OR is pretty busy that day. It's about 2 o'clock. And there was just a code 88 called on D7 South. So in terms of the entire care of a critically ill intubated patient, airway management occupies a tiny fraction of that patient's care. And yet it's one of the highest stakes periods in that patient's care. Following airway management, we pivot into post-intubation care, where things start to settle. And then that patient will have his or her continued critical care. And then ultimately, there'll be some form of a resolution in the form of hopefully an extubation with a discharge home, or potentially that decision about whether to pursue a tracheostomy, or sometimes a withdrawal of care, depending on the patient's goals of care. But today's focus is going to be on that critical period of that airway management. So the objectives are to understand why we intubate patients, be able to identify features that predict a difficult airway, learn about the equipment needed to manage the airway, learn the process of RSI and when to consider alternative approaches. So how many times do we intubate at Kings County? So I looked at data from the last year and a half up until 2 days ago through Epic, and this is derived through procedure notes where the procedure was an intubation in the emergency department. And from January 2020, you can see the peak of March. In CCT, actually in the emergency department, because in March of last year, patients were even intubated in peds, adults, as well as in the main adult ER due to the surge. We intubated about 38. My suspicion is this is probably an underestimate for that month, including March and April. But on average, we intubate about 23 times per month. In 2020, we intubated about 289 patients. So I was curious, how does this compare to other places? Is that a lot? Is that a little? Is that not so much? And this is just Kings County. This doesn't account for downstate or NYU, the site where you guys rotate. So collectively as a group, we probably intubate about 300 plus times per year. So we can look at registries, national emergency airway registries, for data on emergency department intubations. And this is the group out of Brigham's that are involved in the difficult airway course and the authors of the emergency airway management manual. And they looked at spanning about 10 years, a decade or so of ED intubations, and found about 18,000 distributed over about 13. So it corresponds to about 150 intubations per year per institute. So we double that rate. With that said, I looked at another paper that we'll discuss about the Bougie increasing first pass success. And that was a study that looked at 380 versus 380 over a 1 year span. So that institute, Hennepin County, intubated about two to three times more than us. So there's multiple reasons why that occurs. But overall per year in the United States, there's about 300,000 intubations in the emergency department. There's about 15 million if you look at the OR, but 300,000 or so in the emergency departments across the US. So if you think about, we are approximately 300, 1 in 1,000 intubations in the USA occurs here at Kings County alone. So 1 in 1,000, 0.1% of ED intubations. So this is data from that paper, that National Registry on Airways. And the thing I find interesting is if you look at the PGY level, it looks at who's doing the intubation. Mostly residents, and it seems like the best are the PGY 5s plus, but there's a little potential skill decay between PGY1, 2, and 3, and that probably corresponds to the more advanced providers performing much more difficult airways. The interesting thing is if you look at the attending in anesthesia, it's 72% and 74% first pass success. Again, pointing to that selection of probably much more difficult airways. But all in all, we do very well as a specialty, even though the first pass success rate based on this is 85%, about 98% eventually do get intubated, 99%. And the rate of surgical cric is less than 1% over the past 10 years. So it's interesting data about ED intubations. So why do we intubate patients? Based off of the same registry for a host of reasons. I highlighted combative trauma because it'll come up again. So again, that patient that may not have a severe traumatic injury, but because of agitation, we need to sometimes manage the airway to actually exclude that there's anything serious going on from a traumatic and medical reason before continuing with their care. So I looked at another interesting book. You have access to this on Downstate's library, Extraordinary Cases in Emergency Medicine. And the first chapter is all about airway management. And again, these are unique cases that we could potentially encounter, and some of which we encounter all the time at our home institutes. So, epiglottitis, the patient that swallowed a push pin, angioedema, smoke inhalation, food bolus obstructing the airway, removed by McGill forceps. And who knows what happened with this patient? If you look at a textbook, why we intubate patients will be broken down into these three categories: the failure to maintain or protect the airway, failure to oxygenate or ventilate, or an anticipated clinical course. I prefer this breakdown of why we intubate patients, and I heard this for the first time on an MRAP episode 4 or 5 years ago. This is Ruben Strayer trying to clarify for someone why that patient was intubated specifically. And I like this approach because you can extrapolate it to a lot of other aspects of that patient's care. So problems with the airway, epiglottitis, cervical trauma, laryngeal trauma, Ludwig's angina, ACE inhibitor induced, or any kind of angioedema, severe anaphylaxis that's obstructing the upper airway. Those are dynamic processes that are affecting the airway, that the tempo of that patient's care is dictating whether we should manage their airway. Breathing. So this is our respiratory failure patients. These are our patients with COPD, asthma, sick enough to get intubated, ARDS, pneumonia, the flash pulmonary edema, where despite non-invasive and nitroglycerin, we've had to go to the point of intubation. Circulation. So patients in various shock states with severe acidosis, hemorrhage, hypovolemia, sepsis, to offload the respiratory muscles. And then disability, patients that are intoxicated to the point that they have a low GCS and can't protect their own airways, status epilepticus, severe spontaneous intracranial hemorrhages, TBI. These are the patients that can't protect their airway. And then expected course. One of the A through Ds is expected to happen, hasn't happened yet. And then F for freaking out. Now, the interesting thing about grouping it this way is when I think about it this way, and I actually approach it this way. When I think of a patient that's going to be intubated for an airway reason, I'm very concerned because that's typically the patient that is going to have a difficult anticipated airway from an anatomic perspective. And so oftentimes that'll be the group of patients where we may or may not will potentially recruit a consultant like anesthesia, surgery, or ENT, or the patient may be whisked away to the OR for an awake intubation. The breathing patients, the respiratory failure patients, they may not have a difficult airway from an anatomic perspective, but when it comes to the point that that paralytic wears off, we're going to have some challenges with the ventilator management. So you can imagine the ventilator management of a sick COPD or asthmatic or ARDS patient is very challenging. These are the patients that we prone. These are the patients that sometimes we have to add on a paralytic. The circulation patients, they may not have a difficult airway. Their vent management may be straightforward unless they're very acidotic, in which case we have a response to that. But their response to induction and transition to positive pressure ventilation may precipitate cardiovascular collapse. And so we have to anticipate that as well. The disability patients, these are patients that if they have an irreversible process, would tend to move towards an earlier tracheostomy up in the ICU. But if they have an immediately reversible process, for example, a GHB overdose or a severe ETOH or a severe sedative hypnotic, which is potentially reversible, in addition to the freaking out patient, is a group of patients we could actually potentially consider extubation in the emergency department to save resources in terms of ICU beds. This is a talk for another time, but it's those two groups that there is potentially a role for extubation in the ER. The airway patients know, the breathing patients know, the circulation patients know, but the reversible tox and potential agitation patient, assuming there was nothing that was found on imaging. So how do you assess for a difficult airway? And how often does a difficult airway encountered? Based off of that initial registry, about 15 to 17% of the times. So if you look at the number of times that we intubate patients, let's say approximately 300, that's about 30 or so difficult airways per year, at least. And my estimate is that it's higher than that. So we look at attributes of anatomy and physiology, and there are guidelines that speak to difficult anatomic airways and guidelines that speak to difficult physiology when it comes to managing the airway. So when we think about a schema for difficult anatomy, we want to assess for predictors of difficult laryngoscopy, either direct or videolaryngoscopy. We want to assess for difficult mask ventilation, supraglottic device placement, and front of neck access, surgical airway. And the difficulties that we assess here are about our challenges for intubating that particular patient. When we have that assessment in mind, we simultaneously in parallel assess for difficulties with physiologic airway issues, including refractory hypoxemia, circulatory shock, metabolic acidosis, pulmonary hypertension or RV failure. Is the patient a neurologically impaired patient? Is there significant emesis or blood in the airway? Is it an obstetric patient? And that assessment is really how the patient is going to respond to our sedative agent and transition to positive pressure ventilation. And the output of both of these assessments, be it the anatomic airway assessment and physiologic assessment, is going to guide us in terms of deciding whether we go with a traditional RSI approach, DSI, the delayed sequence intubation, awake intubation, or if we're in a pinch, and we are forced to RSI with at least a first look and first rapid attempt. Now, in the vast majority of cases, and based off of our registry data, we're going to be performing an RSI and we'll be successful despite our difficulties. So our goal is to assess the airway and find and come up with approaches and a plan of attack to mitigate that risk. Let's see here. I don't know why it's not advancing. Oh, okay. So from the difficult airway course and the emergency airway management manual, there are a couple of mnemonics that are derived from studies that look at predictors of difficult airway. So the lemon mnemonic is about difficulty with direct laryngoscopy, not videolaryngoscopy, direct laryngoscopy. And so essentially you look externally, you evaluate something called the 3-3-2 rule, which I'll show you. You assess a Mallampati scale, you assess for any upper airway obstruction or if the patient is morbidly obese, and assess neck mobility. And there was a prospective validation that looked at a modified Lemon score, which removed the Mallampati assessment. And essentially it was found that it was helpful if everything is negative, in at least giving some level of insurance. When everything is negative in that study, there was about a 2% chance of encountering difficulty. Anytime we're assessing for difficulty, we're planning for it, we're anticipating it. The difference between a difficult airway and a failed airway is something that we encounter. So just from a gestalt look, this is going to be a difficult airway. If this patient were hypoxic, hypotensive, in respiratory distress or in extremis, this would be a very challenging airway by all means, from a direct laryngoscopy, a surgical airway, bag mask ventilation, being able to position the patient. So this is what I mean in an extreme form, that this patient should make you feel nervous. So the 3-3-2 is essentially taking the patient's own digits, and again, assuming the patient is cooperative and we're able to do that assessment. And this is testing for what we can actually fit into the patient's oral cavity. Can we fit a direct laryngoscope or a videolaryngoscope, an ET tube, 2 suction tubes, maybe a Bougie? The hyomental distance is about space for the tongue to be displaced with the laryngoscope blade. And then the hyomental is about that acute angle that we have to overcome in order to visualize the glottis. Then we transition to the Mallampati, and again, higher Mallampati scores, class 3, class 4, predict more difficulty with laryngoscopy. And again, what can we fit into the oral cavity when it comes to doing laryngoscopy? Obstruction or obesity, universally in all of the assessments, predict some form of difficulty with anatomic airway assessment. But we have ways of overcoming that by positioning the patient with a ramped up position and ear to sternal notch. And then again, we may not know this, but patients with rheumatoid arthritis, spondyloarthritis, or if they've had a spinal fusion, that may limit the patient's neck mobility. So if you're trying to hyperextend the airway, you may run into some trouble. So that's the lemon mnemonic, and all of that is about difficult laryngoscopy. And so that's an assessment when you're coming to a patient's airway that you want to do in your mind's eye with every patient. What about difficulty with videolaryngoscopy? So this is mnemonic also from the manual. It's the Crane mnemonic. So C for contamination, or a Cormack-Lehane grade 3 or 4 with direct laryngoscopy. So if you have that data either from a chart that shows a prior into difficult airway from anesthesia or another ED provider, or you've transitioned from direct laryngoscopy and you had a grade 3 or 4 view, that's going to be a predictor of difficulty with VL. Radiation, abnormal anatomy, again, problems with flexion deformity, and then is there an enlarged tongue that you can't overcome even with the video, or epiglottitis? It's proximal to the vocal cords, and so you'll still have trouble with visualizing the cords. And so to the bottom right, we'll bring this up again, is that Cormack-Lehane grade 1 through 4, and this is views that we visualize with direct laryngoscopy. So that's videolaryngoscopy. Now for BVM, we have the Mohs or Roman mnemonic. And again, it's, can we get a good mask seal? Is there obstruction or obesity? Is the patient over age 55 to 60? Somehow that predicts difficulty. No teeth. So if the patient has no teeth, it's more difficult to get a good mask seal. So we keep the dentures in during ventilation, remove them for intubation. And then again, stiffness. So if there's airway resistance or poor lung compliance, it's much more difficult to ventilate. And so this paper is where some of these features are derived from. And again, the chance of an impossible BVM is pretty rare, 1 to 2%. But again, I think we encounter not too infrequently challenges with mask ventilation. The importance of this assessment, though, can't be understated, because at the end of the day, if we encounter difficulty with direct laryngoscopy or videolaryngoscopy, this is how we bag the patient up. This is how we assess if the patient can be oxygenated and ventilated. If the patient cannot be ventilated and they cannot be intubated, this is where we start to transition to that can't intubate, can't oxygenate, where we get very nervous. So ultimately, this is the rescue device for that particular setting. And so we have a mnemonic for that. And again, that's another thing that we want to assess. So this is the Rod's mnemonic. Again, restricted mouth opening, how much space is there to fit the device into the oral cavity, obstruction or obesity, is there any kind of distortion of the upper airway anatomy, and stiffness and resistance. This is the rescue device that can bridge us to a decision about surgical airway or moving to another device when we can't intubate or can't oxygenate. But again, that clock is always ticking. And then finally, for the last limb of the last corner of that airway anatomic assessment is assessing the anatomy and landmarks for surgical airway. So smart or short, as a patient already had surgery, is there a mass, a giant goiter? Is there problems with not visualizing the anatomy because of a short neck? Was there prior radiation because of head and neck cancer, or is there a tumor? So all of those assessments are how we approach, from an anatomic procedural perspective, how easy is it going to be for us to place the ET tube through the vocal cords? And we should be doing these assessments as we plan our attack for that patient's airway. From a physiologic perspective, hypotension, shock, If you're starting out this low and the patient's in a shock state from whatever cause, and you come to induce them and transition them to positive pressure ventilation, we can precipitate a peri-intubation arrest and hypotension and cardiac arrest. And so we want to mitigate that risk. And so one approach is obviously replace what's missing, be it fluids or blood products, or if the patient is severely septic, vasoactive medications like Levophed, and that provides a buffer for when we come to induce the patient. Hypoxia. So a lot of times we're intubating because the patient is hypoxic. And so one of the approaches is to pre-oxygenate them, because we don't want to approach that steep decline on the oxyhemoglobin curve. And so not all patients are created equal, and we'll discuss about the different modes of pre-oxygenation. Acidosis. So if we have a severely acidotic patient, toxic alcohol, DKA, severe renal failure, we want to try to minimize that apnea time lest we precipitate an arrest because of worsening acidosis. And then also our ventilator management after the patient's intubated should account for the degree of acidosis by matching their minute ventilation requirements. The patient has pulmonary hypertension, be it acute on chronic, or if it's acute because of massive PE. First of all, we want to try to avoid intubating. But the first intubation I had ever was actually a crashing PE patient, my first year in CCT. But needless to say, using bedside echo to assess cardiac function, if that's a patient that we have to intubate, can guide us in terms of how we can add on inotropes, vasoactive medications, whether or not to give fluids, whether or not to diurese, whether or not we can potentially hold off on intubation, but if necessary, we can try to minimize the mean airway pressure on the ventilator. So all of these are extra precautions that we can take with that specific patient population. And then the upper GI bleed or soiled upper airway, there are various techniques that have been described in the literature, the salad technique, the decanto decontamination technique. So really this boils down to whether or not you want to place an NG tube while you're pre-oxygenating and making sure you have really good large bore suction to clean out the airway so you can maximize your views. Pregnancy. Pregnancy has unique upper airway physiologic changes. The airway is more friable, it's edematous, they desaturate much more quickly. There's lower lung compliance. And so we just want to be aware of that we want to try to anticipate those changes with the upper airway in advanced pregnancy. So taking those two assessments together, the anatomic and the physiologic assessments together, we can plan an appropriate risk mitigation approach to the patient's airway. So now talking about RSI, the steps to RSI, we start with preparation, pre-oxygenation and / apneic oxygenation, and transition to paralysis and induction, patient positioning, placement of the tube, and then move to post-intubation management. So part of the preparation, we want to get all of our airway equipment. And so there have been several changes in the CCT with regards to airway equipment that's available. And so to point out, we know what we want. We want to have the direct laryngoscopes, ET tubes, BVMs, nasal oral airways, a syringe, an ETCO2 or VLs, or just stylet. So almost everything we need is located in these orange airway boxes. One thing is important to note is the Bougie is not available in the orange airway box. What is available in the orange airway box is actually something called a Cook airway exchange catheter. And the difference between the Cook airway exchange catheter and the Bougie is the coude tip. There is no coude tip on the Cook airway exchange catheter. Another addition to the Cook airway exchange catheter is that top adapter that you can actually ventilate through. We use this sometimes in the ICU for difficult extubations. So if we anticipate that somebody is going to be a difficult extubation, I had 2 of these just recently last week in the unit, post head and neck cancer, so large hematomas and drainages, or if somebody has a deep neck space infection and we're still worried about once the ET tube is removed, if they will obstruct, we will sometimes place an airway exchange catheter, leave it in place, remove the ET tube, and observe the patient. That way we still have access to the patient's airway should they declare themselves that they need to be reintubated. So the Bougie is not located in that airway box, and so that's really important. The other thing is the rigid stylets. I think just to universally make it simple, even I've confused this too. There are the black top and blue tops. The blue tops are reusable. We should all just assume moving forward that they're reusable. But what if they're out? Can you use a regular stylet? The answer is yes, you can use a regular stylet. You just have to fashion it in the shape of a rigid stylet if you're going to do videolaryngoscopy. We have the GlideScope core at CCT, and this week or next week, we'll have the disposable bronchoscopes added, and their placement will be in CCT medication room behind the door. So we're just placing a hanger up, and based off of our prediction of how often they'll be used, we'll have 3 there that will be monitored and stocked. So that's about the equipment that's available. And importantly, the video scope that we have, we use the hyperangulated blade. So we don't use the regular geometry Mac blades. We use the hyperangulated S3 and S4 blades. So when it comes to pre-oxygenation, our goal is to try to increase the safe apnea time and avoid any kind of desaturation during apnea while we're trying to get the airway. So we can pre-oxygenate, and we can keep the patient on nasal cannula via a regular low flow or high flow, low flow at flush rate or a high flow device. And our goal is to try to avoid desaturation. Now, several patients, because of comorbid illness, body habitus, advanced pregnancy, will tend to desaturate much quicker. So it's just important to know that once a paralytic is delivered, that patient has a couple minutes tops. Oftentimes it's a lot less in reality. At least that's what it feels like, to the point that they reach that steep portion on the oxyhemoglobin curve. But remember, some patients were starting out 95, 96% plus, relatively low risk. Some patients were starting out, they are at 80, 85%, just to think back to last year and with COVID, starting out 70%. And so that becomes a risky airway because of the high risk of a precipitous drop in their oxyhemoglobin curve. So assessing that risk for desaturation can also inform us in terms of how we approach pre-oxygenation. So in our low risk patients, we can pre-oxygenate them with our oxymask and nasal cannula, and then continue that and keep the nasal cannula for apneic oxygenation. For our higher risk patients on the opposite end of the extreme, sometimes we actually have to do recruitment with positive pressure and not just high flow. So we can incorporate use of high flow nasal cannula, and just a pearl for high flow nasal cannula. Each 10 liters of flow plus or minus corresponds to about 1 centimeter of water pressure. So if we put somebody on 50 liters of flow, you can imagine that that's about 5 centimeters of CPAP, plus minus. That's a gross oversimplification. And for our highest risk patients still, we can incorporate CPAP and or BiPAP for pre-oxygenation, and then keeping the nasal cannula on for apneic oxygenation. So these are the devices that we have available in CCT to utilize for pre-oxygenation. So we have, obviously, most of the times we're using the oxymask with the run-of-the-mill nasal cannula. And we have 2 high flow nasal cannula devices. We have the OptiFlow and Airvo, and then our non-invasive devices, 2 of which can also be used for invasive ventilation. It's our LTV and our Ravel, but we have all 4 devices at exposure. So just being aware of that and being able to communicate that with respiratory therapy. This patient's a little bit of a high risk patient. They're too hypoxemic. I'd like to recruit them up a little bit. We have these devices in CCT. And then this is from a up and coming guideline that Jane wrote on our respiratory therapy that will come out hopefully in the next week. So patient positioning. Not all positioning is appropriate. In fact, some patients we would want to pre-oxygenate them completely upright. And then once we're positioning them with induction, we want to try to have that ear to sternal notch ramped up in our morbidly obese population. And that will hopefully potentially optimize our laryngoscopy. So paralysis with induction. So the induction agents, based off of the study, we can also look at what people are using overall. So etomidate seems to be the most commonly used agent. It's hemodynamically pretty stable, and so you could almost make a case for using it in all instances. And the dose is 0.3 milligrams per kg, so 20 to 30 milligrams. The use of ketamine has significantly increased over the past decade or so. And again, sometimes ketamine can also precipitate hypotension if the patient is in severe shock. So, and how you predict that? Again, if the patient looks like they're in a severe catecholamine surge, which is oftentimes the case in a severely sick patient, you may get that paradoxical response, despite the fact that it's a sympathomimetic. Propofol, it is 2 mg per kg or 1 to 2 mg per kg. Its main adverse effect is hypotension. So potentially in severely hypotensive patients, you may want to avoid that. In all of those cases, though, you want to just decrease the dose, maybe half the dose, be it ketamine, etomidate, or propofol. When it comes to paralysis, there's always this discussion about sucks versus rock. I'm pretty neutral, although I prefer, so I guess I'm not that neutral, prefer rock. There are good arguments in both cases. Looking at data from that study, there has been a pretty steep decline in the use of sucks compared to rock over that 10-year period that they looked at it. And it seems to be about a 50-50. I tried to ask our pharmacist to see if we can look at a search about what we use just to get a little data. We couldn't get that, but well, actually it ended up generating a lot of anesthesia data, but from the 4 cases in the ER, it was all rock. But you know, personally, we do tend to use both. The proposed benefits of sucks versus rock are that its duration of action is short enough that a patient would be able to wake up and regain spontaneous ventilation. And so in difficult airways, that may be a plus. Personally, and from my interpretation of looking at the literature and discussing with better airway managers, is that is actually a disadvantage, because if the patient actually has a difficult airway, you want to make your environment as optimal as possible. And so you want a completely relaxed patient, assuming you've committed to getting that airway. Also, once the dust is settled, oftentimes immediately once you pivot to the immediate post-intubation care, you want a completely relaxed patient so you can perform your diagnostic imaging if it's a trauma patient. You don't want the patient waking up right after sucks and then the trauma team is yelling, this patient is not adequately sedated. It's appropriately relaxed on their way up to the OR, whether it's through CT or not. And then again, the contraindications. Sucks has a whole list of contraindications that you don't have to really think about when it comes to rock. Rock does have a reversal agent, which we do have at Kings County. We don't have it in CCT, Sugamidex. Anesthesia has it, but we can order it. So when it comes to actually coming to the procedure itself and performing the laryngoscopy, you want to think about the 3 axes of the airway in your mind's eye as you're performing the laryngoscopy. There's the oral axis, what you can visualize directly when you're looking down at the patient's mouth, the pharyngeal axis, and the laryngeal axis. And our goal when we come to position the head, the necks, whether we're extending or flexing, is really to try to align these as parallel as possible. That's the way we're going to maximize our view of the glottis. So let's say you come, you place the laryngoscope, you sweep the tongue to the left, you're placing the tip of the laryngoscope, if it's a Mac blade, in the vallecula, and you're hopefully trying to generate that grade 1 view. But again, this is that Cormack-Lehane view, that 1 through 4. 2 and 3, they have an A and a B, so it can be a little bit more complicated. But we're trying to get at least a 1, 2, and sometimes a 3. 4 is anxiety provoking. My own anecdote is my second year at Downstate, I had a patient crash on me, and I was with Dr. Silverberg, and he gave me an opportunity at the Airway, and I saw a 4 once I placed the laryngoscope. And Dr. Silverberg looked at me, and I remember his gaze, and he asked me, "What do you see?" And if I had an EKG on me at that point in time, my heart rate would have been an SVT at 220. And I couldn't get the airway. So he moved in and got the airway that was smooth. And what he did, his move was actually to pull out, retract the laryngoscope. I had just dived into that airway too deep. And I created falsely a grade 4 view. And oftentimes that's a pitfall when you're first starting out with airways, is we are very nervous. People are asking you, and by the way, Dr. Silverberg was very supportive after that. I know he's on the line, and taught me a lot about that airway. But we often just plunge the laryngoscope deep into the airway and we overshoot. And so that's anxiety provoking. Kindly raise your hand if you have encountered this already. Thank you. Thank you. I still encounter this, and sometimes it still happens. The point is to know that that is a thing and how to respond to it. The point is to be able to control our own anxiety and be able to anticipate and know all of these details and know how to troubleshoot when we encounter this. So if we're having difficulty, remember we have another hand, we can do external laryngeal manipulation and ask an assistant to hold the airway so we can maximize the view. So I like this approach that Rich Levitan and George Kovacs describe, where they incrementalize the steps to the laryngoscopy, where you first look for a first landmark. Obviously, you're doing this all simultaneously. You look for a first landmark, slowly inch your way a little bit at a time until you see the next landmark, and then perform your steps, really understanding the functional anatomy of the airway. So this first thing is about when you do dive in to try to avoid going in, is actually going in relatively shallow, sweeping the tongue to the left, and anticipating seeing that first view of the epiglottis, knowing that you have to go in and engage what Dr. Valesky loves telling us is engaging the hyoepiglottic ligament, and then lifting the epiglottis forward. And so this is that hyoepiglottic ligament. If you lift the tongue too soon, you may not gain a lot in terms of the epiglottis moving up. If you go too far, you may obstruct your own view. And so it's being able to be aware of that balance of putting the tip in the appropriate spot and then lifting the epiglottis forward. So what about Bougie? So this is that study I was talking about. This is in Hennepin County, where each arm, this is a one-year study, had 380 patients. That was 760 airways in a year. I was curious about this, and so I went to Google Maps and I looked, how many hospitals are there? I was curious, how does it compare to New York City? It looked comparable, but needless to say, this was a study that looked at a CMAC. So using CMAC with Bougie and then intubation over Bougie. And so the CMAC is, again, it's not the hyperangulated blades that we use for our video devices. It's a traditional geometry blade versus a styleted ET tube. And they were able to have a first pass success rate of about 98%. First pass success. Again, from that prior study, it was 85% overall. So that was a pretty significant difference. And then that benefit was really realized in the grade 2 and 3 Cormack-Lehane views. And apparently, per the paper, they didn't use the video monitor. They were really using it as a direct laryngoscopy blade. And so the important thing is how do we extrapolate that to us if we don't have the regular geometry blade? And how do we use a Bougie when you have a hyperangulated blade? When you take out the Bougie from the package, it's pretty straight. So you have to add a curvature. You can still use it obviously with a hyperangulated blade, like we have the glide scope. You just have to add that extra curvature to overcome, to prevent it from going to the esophagus. But this is rather thought-provoking and potentially encourages more Bougie use. And one of the explanations is in these grade 2 or 3 views, the Bougie, you're able to visualize it directly going into the cords as opposed to the ET tube itself, the tip, obscuring the vocal cords when you're approaching the airway, when it's that tight. Okay, so we've got the airway, we've transitioned to placement of the ET tube, inflated the syringe, and everything goes well. Of course, it's not that easy. We've either decided to start with direct laryngoscopy and we're encountering difficulties. So now we're encountering a failed airway. I like this quote. Insanity is doing the same thing over and over again and expecting different results. Albert Einstein. So if you're encountering a difficulty, again, this is anxiety provoking. And the important thing is not to do the exact same thing. It's to make an adjustment, either to reposition a patient, think about what went wrong, reposition your blade, let somebody else give a try, or do something else. So the save, again, goes back to the BVM. If we're having trouble with laryngoscopy, we can rescue ourselves if the patient's becoming hypoxic by bagging the patient or continuing to oxygenate them. And again, there's 1- and 2-handed techniques, preference for the 2-handed technique in a bad emergency. And sometimes we can place our oral or nasopharyngeal airways. And again, if we're having trouble with BVM, we always have a rescue attempt with our LMAs that we can also ventilate through. So what about using directly, just going straight to video and not doing that transition of starting with DL and then going to VL? Again, with the introduction of all of these new technologies, the number of DLs has gone down, and we've transitioned more to VL. So VL, again, we have the GlideScope core. And it's important to note that when we use a VL, we're using a hyperangulated blade. And then this is just a diagram about comparing the hyperangulated blade compared to the traditional Mac blade. And so this is the type of view you want to generate. So for our purposes, though, and thanks to Dr. Lucchese, we'll be getting pretty soon this device. This is the next device that we'll have, and this is a traditional Mac blade configuration. So this will serve as our video with the traditional Mac blade, handheld. We should be getting this over the next few weeks. And once that comes out, we'll obviously send out information about how we start using this in the emergency department. So, and this is just a side comparing it to our hyperangulated blades. So in terms of the two views, which would you prefer, the one on the left or the one on the right if you're doing a VL? The one on the left, right? And the reason is you want to occupy 50% of the screen. You want to make sure that you're sacrificing a little bit in order to optimize your tube delivery. If you generate this view and you're too close, you're going to have trouble with tube delivery. It'll potentially get caught up on the anterior structures, cricoid ring, and you may not even be able to see it and maneuver it. So you want to try to back up if you generate this up front, similar to the DL, back up a little bit, let the epiglottis fall down and lift a little bit so you can optimize your tube delivery. What if you're encountering difficulty with the VL? This is where the disposable bronchoscopes potentially come in handy, and we've done several in trainings with faculty and residents. You can use both split screen to deliver the ET tube and confirm your tube placement, as well as your distance of the ET tube tip from the carina. And so the disposable bronchoscopes can either be solely what's seen on the console with transitioning between the VL and the bronchoscope, or you can do the split screen on either way. Again, another tool that we can use. And so the way we're thinking about potentially starting to use this is when we're encountering difficulty with VL, which does happen, but not as as solely an awake airway intubation. That's something that would potentially happen later on, but solely as a rescue for difficult or failed VL. And now again, once you get that ET tube in place, you always want to confirm placement. So with the capnography, and then my preference is always every intubated patient should have an end-tidal CO2 for gas exchange, non-invasive gas exchange monitoring, because you can act on a lot of data from the end-tidal CO2 that we learned about in the first lecture of the year, EMCCM. And that's it. So once we get that airway in, you're not done. You secure the tube, you confirm your appropriate depth, complete the indicated diagnostic workup, provide adequate sedation, order the appropriate vent settings, and then you continue your further resuscitative care. Fluids, pressors, antibiotics, and nebulizers. And that is it. Any questions?